I am going to start things off just so that we can keep moving. So, good afternoon, everybody, and welcome to the third in our DeNPRU Exeter webinar series. Obviously, this time focusing on the topic of living alone. And this is a policy research project that has recently finished. So, we're in a position to kind of present results. So, we are DeNPRU Exeter, but what is DeNPRU Exeter? Well, although Exeter is in the title, we actually collaborate with several universities and colleagues around the UK and indeed, as you may have noticed, in Australia. So if you're thinking, well, gosh, Exeter's a far way from where I am, we actually might be closer to you than you think because we have researchers in Bradford, Newcastle, LSE, and a collaborator in Hull. And if you're dialing in from very far away, then maybe Sydney is the closest to you, I wouldn't know. So, policy research units, we are funded by the National Institute of Health and Care Research, and they're composed of experts and researchers who undertake policy research rather than primary research. So we're here to provide evidence to support national policy making in England through the Department of Health and Social Care and its arm's length bodies. It's important to note, however, that of course, while we are funded through them, the views expressed here are those of the authors and not necessarily those of the NIHR or the Department of Health and Social Care. So what are we in for? Well, the schedule of events for today is that we're going to have a presentation around the Living Alone project from Professor Linda Clare, who is our director and led the research for this particular project. I'm then going to have a little conversation with Jane and Nick, who were our experts by experience on the Living Alone project team, just to give you another perspective around living alone. And then we'll open up for audience Q&A. Okay, so please do get involved. We would love to hear your questions and your feedback. And at this point, I'm going to stop sharing and hand over to Linda.
Okay, so I'm going to share with you what we have been doing in this project and what we have found, so that we can then go on to discuss where we go from here. I'll just start by, I'm just going to show you and acknowledge the project team. So all of our work is large emphasis on teamwork, and this is here to remind me first of all to acknowledge the team, but especially to thank Jane and Nick, who are members of our friend network, our involvement network, who've contributed to this this specific project, as well as being part of our wider network and contributing in various other ways as well. So why did we decide to focus on people living alone with dementia or another neurodegenerative condition? Well, for me, this was partly from personal experience and partly from previous research. That's what triggered my interest in the topic. We know that about 1 in 3 UK households are single-person households these days, and that's been an increasing trend, especially among people in older age groups. We know that a significant number of people living alone, especially in later life, will be living with other health problems, including dementia or other neurological conditions. Generally, in thinking about services and research, there's often an assumption that people have a family member or other unpaid carer available and near at hand and able to support them day to day, which is not necessarily the case. And neither NHS services nor community services are really designed to accommodate the needs of people living alone. They've been generally built on the assumption of the kind of traditional assumption of a partner, or a spouse, husband or wife being there, or perhaps an adult child nearby. And we also note that some research excludes people living alone by requiring a carer to be available and involved, fill in questionnaires and so forth. So that in our research, we're not getting the full perspective very often, which of course makes it less likely that we'll be aware of the needs of people living alone. So we think it's time for this to change. Just a word about what we mean by living alone. Of course, people living alone with dementia or another condition are a diverse group, and people live alone for various reasons. Some have always lived alone, others may be living alone due to a bereavement, and everyone's circumstances are different. So we're not thinking of people living alone as one group. We know that people have varying levels of support. That might be good support from family and friends nearby, Some might have family at a distance in another county or country even, or continent, and who wants to be involved but is not near at hand. And others have little or no support, meaning that life alone can be quite precarious. We had a large study called IDEAL, which looked at over 1,700 people with dementia, recruited through memory clinics in Great Britain, and about 18% of those, nearly 1 in 5, were living alone. And of those living alone, about 18% said they had little or no support from family or other networks. In a recent German study, that proportion was 10% who had little or no support. And similarly, about 10% had no one who could respond within 24 hours to help them in an emergency. So we do need to think about needs of people living alone. It's really important. So what did we do in this project? Well, this is a policy research project, and we aimed to do several things. First of all, we wanted to find out how many people are living alone with dementia or another neurological condition. So we analysed national data collected from GP practices, the CPRD database, to find out the proportions of people living alone. We looked at the research evidence to find out what has been written, what's already known about living alone with these conditions. We also looked for the information and advice that's available to people living alone, or their families, or the professionals who are involved in supporting them. And we talked to people with lived experience, to health and care practitioners and other key informants to get their perspective. And by putting all of that together, we wanted to identify what needs to change and to share those key messages. And today is part of that process. So first of all, how many people are living alone? So we found that people living in the community, so I'm excluding care homes and hospitals here, we have 40% of people with a dementia diagnosis living alone. That's those with a diagnosis, I emphasize. We have about 1/3 of people with Parkinson's, and 1/3 of people with motor neuron disease, and 38% of people with Huntington's disease. And we focused in this project on Parkinson's, MND, and Huntington's because these are conditions where there are sufficient numbers to do these analyses and get a robust picture of what's happening. A lot of the learning, I think, would translate more broadly to perhaps rarer conditions as well. So yes, high proportions, higher than what's often quoted in research studies. Typically, we've been hearing 1/3 recently, but it's more than that, certainly for dementia. And who's most likely to be living alone? So here I've listed what we found for each of those conditions. Dementia and Parkinson's, that looks pretty similar. Women, especially in older age groups. Black people more likely than white or Asian people. People living in an urban area and a more deprived area. London also comes up consistently, obviously, as one of our main urban area. Slightly different picture for MND. Men are more likely to be alone, again, towards the older end of the spectrum, otherwise similar. For Huntington's, we had relatively few numbers, but we found no difference by sex or age. And again, we saw the trend for it to be more people in urban areas and more people living in deprived areas. So we can start to see that we might be thinking about inequalities here within that group of people living alone, in terms of some groups that might be less likely to receive or access services or receive support. So what does research tell us about? I'm going to start with dementia here because that is where we found the most evidence from the research literature. We found 200 articles published in journals, mostly from Europe and North America, and they reported 161 separate studies. However, nearly 2/3 of them did so only to tell us how many of the participants were living alone. Nearly 1/3 did focus specifically on living alone, and then there was a smaller group that included, among other analyses, whether there were differences due to living situation. So we had a number of articles that compared people living alone to people living with others, or they described challenges for people living alone, for their families, and for practitioners who support them. One thing that struck me most strongly among these 200 papers was there were hardly any that talked about ways of supporting people living alone better. And there was only one that focused on supporting families who were trying to support a relative from a distance. When we looked at the papers comparing people living alone and people living with others, the main finding, and this probably won't surprise you, is that people living alone with dementia are not different in some specific way from people living with others. Their dementia is not different, the severity is not different, the symptoms are not different, their general health is not different, nor is the use of health services. But what is different is that relative to people living with others, they can experience specific inequalities in relation to diagnosis and care. And I'll say a bit more about that. So I've put this in terms of the pathway about diagnosing well, living well, supporting well, and dying well, that people living alone, compared to those living with others, tend to experience later and less precise diagnoses. There may be, as a suggestion, possibly different prescribing patterns too. They tell us their quality of life, their well-being, and their satisfaction with life is less positive. They're more lonely and isolated. They have greater challenges managing daily activities, and they have more unmet needs. In terms of supporting well, they have more difficulty navigating and accessing services and support. Services can be a bit inflexible sometimes in responding to those needs. They're not any more likely to go into hospital, but they're less likely to be discharged home again, more likely to be discharged into a care home, and generally more likely to move into residential care. And when it comes to dying well, and most people would probably prefer to die in their own home, there's a greater likelihood of dying in hospital or in a long-term care setting. So when we talk to people with lived experience of dementia and practitioners who work with people with dementia, some of the things that came out were that, of course, supportive social networks are really important for people living alone. They're super important. It is very challenging to navigate services for everyone, and people living alone may find that especially challenging if they don't have an advocate or spokesperson to help. So we think that people living alone might benefit from a more proactive routine contact by services, and certainly better communication. So services can make sure they communicate with people in ways that are more accessible, for example, through providing written notes of meetings or allowing people to communicate by email rather than phone and so forth. Practitioners want to do the right thing. They want to give people as much choice as they can, but they are faced with decisions sometimes about balancing people's rights to choose against possible risks. And that's a difficult one for them. And again, as I said, people told us that people living alone are routinely excluded from research, and that's just not acceptable. So what about research with the other conditions that we looked at? I'm going to be briefer here because there isn't very much. For Parkinson's disease, we found 18 journal articles reporting on 17 studies that referred to living alone or told us what proportion of people in their study were living alone, but there was nothing focused specifically on living alone. There were 13 studies that compared people living alone to people living with others. And we also found 6 information booklets that offered advice for people living alone. One of the key findings from the research studies was that people living alone were more likely to feel depressed or to develop depression, and they felt less satisfied with their lives and generally had poorer emotional well-being on average than people living with others. If we come to Huntington's disease, we had found only one journal article and one PhD thesis that talked about people living alone. Neither one focused specifically on living alone. And we only found one advice leaflet, which was COVID related. The one thing that we did find here that was described was that living alone was a factor that could contribute to increased suicide risk, which of course is a big concern for people living with Huntington's, and goes along with mental health challenges that they often experience. For motor neuron disease, there were precisely no research articles on people living alone. However, the Motor Neuron Disease Association, which we were in contact with was producing an information booklet for people who are living alone when diagnosed. And we were able to review the proposed text and give some thoughts to the MNDA. And that booklet is now available, pleased to say, for people who may be living alone when they're diagnosed. So when we talk to people with lived experience of those conditions and practitioners, there were lots of issues raised, many of them potentially relevant for anyone diagnosed with one of those conditions, but where living alone can add another dimension to the challenges. Again, it was felt that people living alone are likely to receive poorer care because they lack an advocate or that a spouse or family member can provide. And that's especially so if they're socially isolated and maybe don't have strong social networks, or if the support they do have is available but rather precarious. Again, it was felt that systems and services do operate on the assumption that people have a carer or support network available to do a lot of the heavy lifting, as it were. And there's a sense that there's an increasing expectation that it's families who will provide care, meaning that people living alone are likely to be further disadvantaged. And more than this, and this was something that didn't come out particularly in the dementia work, but that came out more strongly here, was that there was could be a sort of sense of stigma attached to being alone. If you go along to an appointment and there's an expectation that you've brought someone with you and you haven't brought someone with you, there can be a bit of a stigma attached to it in interactions with health professionals, which is obviously unacceptable. So we had some rather poignant descriptions of that. So we found out quite a lot from all of that. So how do we take that forward? What needs to change and how? So we came up with some main messages and recommendations. And one thing that we saw very clearly is that actually people don't really know how many there are living alone with these conditions, and especially how many with no informal support. But it is possible to estimate, as we did. And that in local areas, it should be possible for ICBs to think about how many people there are in this situation and how many people, therefore, they need to take account of when planning and providing services. We did talk a lot about information systems and recording and how hard it is sometimes for practitioners to get all this information down and keep it up to date. So there's a need for systems that allow for accurate and up-to-date recording, and that also that information isn't often shared between teams or health and care agencies when it would be helpful to do so. And so there needs to be appropriate sharing of information. Secondly, we've identified some inequalities in service provision attributable to living alone. And if you have 40% of people living alone in the community, you know, you really need to start from the basis that that's pretty likely. And we did talk to the NHS England clinical director for dementia, and his response as well. And maybe we need to be planning on the assumption that people don't have support, and then if they do, that's great, and if they don't, their needs will be better catered for. We also need to equip and support practitioners to provide flexible, personalised, coordinated care. And I'm saying this because practitioners have often told us that the systems they work in are rather inflexible. And while they might want to do something different because of a particular need they identify, they don't necessarily always have the freedom to do it. And they need the flexibility to adapt to the needs that they see in front of them. And we need to better educate the health and care workforce generally and the public. I think probably many members of the public would be quite surprised if we said actually 40% of people with a diagnosis of dementia in the community are living on their own. And there is a need to be aware of that, and to and really for finding ways, which is my next point, of strengthening community support. That certainly in talking with people with conditions other than dementia, there was more emphasis on this, but support with applying for funding for NHS continuing healthcare, for making home adaptations, practical and financial support. Carers and families who live at a distance often aren't well supported or even given any support in their role at all. As I said, we found one example that was a very nice example of how that could be done. And I think there's more that could be done in that respect. And then community agencies do their best, but often have limited capability, may rely on volunteers, may need to require that a carer comes along because they can't provide that kind of personal support that people might need. So we did come across a really interesting initiative in the United States where where agencies were offered additional funding to specifically undertake projects to address the needs of people living alone in their community. And they learned a lot from doing that. They realized it was more complicated than they thought at the beginning, but they were able to implement some initiatives that were helpful and beneficial. And that would be very easy to replicate in this country. And then the last point is about targeting research efforts in a way that addresses some of these inequalities. So two things here. Firstly, making sure we include people living alone in research. And I understand that researchers want to know how people do in their interventions and may look for a range of information. But can we not design this so that we can allow people who are living alone to take part? Can we not think of ways of making that possible? I don't think it's beyond us. It just needs some thought and work to guide researchers to the possibilities that of what they can do, rather than assuming that they can't include people who don't have a carer living with them and able to fill in questionnaires about them. And then secondly, as I said, we found hardly any research that actually looked at practical implementation of good practice in this area. So that's a very strong steer we can give to funders to look to fund research that we don't need more descriptions of people with dementia living alone, for sure. But what we could do in all of these areas is some evidence about how to change things and how to implement good practice. So concluding comments then, we need to think differently about addressing needs of people living alone with dementia and progressive neurological conditions. That includes increasing awareness, changing attitudes, removing stigma, reducing inequalities. We can do this. There's no reason why we can't do it. We need to engage in better planning, making our services more responsive, strengthening community support, and making our research more inclusive and practically relevant. That's going to benefit everyone. If we're more proactive in supporting people and preventing crises, that will benefit the NHS and social care services, as well as transforming the experience of people coping with dementia or another progressive neurological condition alone at home. So I'd just like to end by acknowledging everyone that's contributed to this, all the people with lived experience and stakeholders who engaged in consultation with us, all the colleagues who shared information about their work, members of our advisory group, our engagement network, our friend network, our colleagues and our wider team, and of course our funders. So thank you very much for listening, and I'm going to hand back to Kathy.
Yes, gosh, a whistle-stop tour through what was represented there is essentially a year's worth of research. So hopefully you'll forgive us if you're feeling slightly windswept by the amount of information that has just poured over you. That is the nature of these things. So just before we open to audience Q&A, because I'm sure that you have lots of burning questions, I'm just going to have a little chat with Jane and Nick. So if you two want to come off mute, that would be fabulous. So I know that sometimes this is called PPIE or patient and public involvement and engagement. We prefer to talk of it in terms of experts by experience. So both Jane and Nick are experts by experience. So if I start with you, Jane, why did you want to be involved in the Living Alone project?
I suppose partly because when I'm an ex-carer, looked after my mum who had dementia, and when the symptoms first started and she started looking at a diagnosis, she was effectively living alone, not just that she lived in her own home, but I was living abroad. I came back to try and help sort out a diagnosis, lived with her for a few months. That didn't work out because things were happening. So moved out to a separate flat. So, and then I was having to work. So she was effectively living alone. So I kind of understand some of the problems we had. You mentioned about diagnosis. She was missing appointments. And until I managed to successfully get linked as her carer, and that things were sent to me, it wasn't always, they did miss out. She was getting appointment letters. She wasn't going to appointments. They were actually talking about striking her off because she wasn't going to appointments. They hadn't thought about the fact it was her memory and joining the dots there. When I did eventually take over her care a little bit more, she hadn't picked up prescriptions for about 3 or 4 months. So all of those things which I realised were happening with mum, and I was able to actually come in and sort out. How many other people? Well, looks like 40% maybe are going through those same things. And even when I did become her carer, those issues of getting the help through speech and language therapy, she had a lot of very early swallowing problems. The fight I had to do, I mean, I think I'm a fairly intelligent, fairly sort of responsible person, but it was a struggle trying to get that sorted out, sorting out her continence supplies, getting the right ones, real fight. And the stress that I went through, I don't know how someone living on their own would cope. So all of that, now I'm living alone. I don't have children, I don't have siblings. So there is a certain selfish, what about me? If I develop dementia in the next, I don't know, few years, I'm in my mid-60s now. So there is a selfish component of what about me? And there is a certain, I try and do as much as I can, but it's very difficult for smaller charities and smaller groups. And a lot of groups that run support sessions are maybe, they haven't got the full setup that some of the bigger organisations have. Yeah. So they just aren't equipped to actually bring in people who are living alone, who don't have a carer to support them. Some of the things I do, it's going to be very difficult for us to do them without a carer present. But also, even things like, how do they get to you if they don't drive and they're not happy and confident getting on public transport? So there's so many issues there. Yeah, so that's not very precise, but that's why I got involved.
No, fabulous. Thank you, because you've already raised some really important and salient points around, as you say, look at all of the different tasks you ended up taking on for your mum. And your mum happened to be living alone, but have somebody who was able to do that. And actually, so many people who we spoke to in consultation with lived experience were sort of saying, oh, well, I did this, or I have this person who helps me. But everybody kept coming back to the question, but what would you do if you didn't have anybody? And I think it's a real fear for people, and understandably so.
For a little while, I worked on emergency care plans we have here in Hampshire, and I helped create these emergency care plans. And I still try and recommend people that should have them. So that's basically our local government actually provide up to 48 hours of care in an emergency if someone, like the main carer goes ill. And what I'm finding is that there are an awful lot of people who are effectively a carer, be it distant relations, neighbours or friends, who don't want to be identified as such. And I think that's a problem in that they are there. So it's a slightly different issue, but they have got people around, but these guys don't want to identify themselves as, or they don't identify themselves as carer, but that means that they're out of the loop for a lot of the things that might be available. And I think that's another thing we need to address. Sorry, thank you, Kathy.
No, absolutely, because of course we know that the term carer is not universally liked for understandable reasons, but that might be what grants you that statutory support. So yes. Nick, what about you? Why did you want to get involved in the Living Alone project?
Well, I didn't really consider living alone as being anything different from living with somebody, because I've been living alone for 10 years anyway. So living alone for the first 5 or 6 years with Parkinson's, I became involved, which is, I think, a big yes for anybody that is wondering whether they should get involved or not. And in the process of being involved with a local Parkinson's UK group, I was invited to appear on the podcast The Movers and Shakers, which has become quite widely listened to around the country. And all of them had partners, and so they were all amazed and awestruck that you could live with Parkinson's and manage on your own. How do you get dressed? How do you do the shopping? How do you cook? How do you how do you do all of these things when you're living alone with Parkinson's? And of course, you listened to that.
I did.
And you contacted me, which impressed me that an organisation like the University of Exeter and DeNPRU would be interested in the problems that people living alone with Parkinson's will face. So it was a no-brainer from there on, and it's been eye-opening.
Fabulous. Yeah, I mean, it's interesting there that, as you say, you know, the reaction of people who have a partner, who have somebody else there, is kind of, oh my goodness, how can you do this? And I think people we've spoken to have also had similar sorts of reactions, but from health and social care professionals, you know, just complete amazement that people are living alone. But as we've seen, you know, a much greater proportion than we might expect are in fact living alone. And so this does need thinking about. Okay, I've got one more question for you two. I'll start with Nick this time. So what do you think people misunderstand about living alone with, in your case, Parkinson's disease?
People with the disease or people generally?
Ooh, I was thinking people generally, but you can take it how you want to, Nick.
Well, I think that the majority of people don't realize how difficult it is living with the disease, first of all. And even people that you're close to, you know, people who are giving you support, either emotionally when you're going through an anxiety period, or whether it's to help do a particular project. They tend to see you when you're on your on period. So when your medication is working and you can converse and be still enough to do things. And they don't see the off periods because you live alone. And those tend to be when you are alone, because when you're off, you tend to want to be alone. So, and deal with things yourself. You've got to surround yourself with the tools that you need to support yourself, whether it's somebody to come by or whether it's a device to help you put your clothes on or whatever. There are lots of things out there to help you. And it's not widely known, funnily enough.
Well, and you've educated me about the socks on device, among other things.
Yeah.
But yeah, no, and I think one of the really important things you said there was around that, yes, if you're not feeling on or you're not feeling good in yourself, you're less likely to be motivated to go out and keep doing things, and therefore people aren't seeing you. And that was something that came up again in all the conditions, but also motor neuron disease and Huntington's disease, that sort of, if you haven't got somebody else around to encourage you to maybe seek out a group or to get some food shopping organized, it just might not happen for somebody who's living alone, because of that sort of apathy and that difficulty of having to do it all by yourself. So
yes, when people join our local PUK group and they want to get some advice and help, the first thing that I tell them is to join a local group, get into research. Research projects around the country are running all the time, and they need volunteers. And try and get involved, and that helps more than anything.
Yeah, absolutely. Thank you very much, Nick. Okay, Jane, what do you think people misunderstand about living alone with dementia?
I think probably a lot of what Nick's just said would apply with dementia. I mean, actually, whether you've got a carer or not, probably people aren't out as much on their, Nick says off days, but maybe they're red days, the days when if you're using a traffic light system, they're not doing so well. But if you have got a carer, then the chances are there is someone else who's at home with you on a bad day, and maybe they can do some things. So if nothing else, you're maybe not quite so lonely. If you are having a bad day, you aren't responsible maybe for quite so many of those chores, or even if a carer is supporting you to carry on doing those chores, they can take over on your bad days. I think if you're living alone, yeah, you're not going to go out, you're going to be at home. And I think that's just going to make it worse, particularly with social isolation is really bad with dementia. And I think the other thing is, Nick was saying that, there's all these things that might help you. There's tools, there's various things that might help you to manage. If you've got dementia, you've got that added thing of actually not remembering that you've got them and not remembering to use them. If you've got a carer, they can prompt you of, oh, have a look at this, or maybe you've got a tool that helps you with whatever you need to do. They can actually, on a bad day, just help you with them. If you're living alone, you haven't got that. So yeah, I think they're very, very similar problems.
Yeah.
Fabulous. Thank you both, because it sort of brings it to life to hear about it from a personal perspective. So thank you so much. Okay, audience, it's that heady moment when we open to Q&A, and somebody has to dare to be first.
So we're commissioned by the Department of Health and Social Care when we have worked with them from a discussion about their policy priorities to set up our work plan of projects that we proposed. And this was one of the ones we proposed to them that they accepted. We also have to respond when they have a policy need. So we are flexible on that. So some things they suggest and some things we put forward based on discussion of the needs. And this was, as I said, one of the topics they accepted. Having got to this point with the project where we've got the reports ready, before we finalised the reports, we presented all of that information to two teams. Department of Health and Social Care and NHS England teams, and those, one focusing on dementia and one focusing on long-term conditions. And the long-term conditions team look after all the progressive neurological conditions, among many other conditions that they seem to cover, some of which they don't even know that they have to cover because they're so rare. So they're both very interested, both teams, very positive to hear about this. The team had some suggestions that we're trying to follow up. And we hope also to be able to work with some of the representative organisations like Parkinson's UK, Huntington's Disease Association, to see whether we can get this, this message across more forcefully now that we've got these findings in place. So that's how we work. And so there is interest, but we don't stop here with the report. We still have work to do to try and get this out there. We're now going to produce a policy brief that will go to the ICBs, and so on and so forth. So we're going to keep working on this message. It's really important. And we saw some very sad comments in some of the qualitative research about people whose company was the television or looking out of the window. This is bad. Loneliness is bad for all of us, and absolutely something that needs to be fought. You're right. Thank you. It's absolutely right. Yeah, I think Nick said you need to sort of surround yourself with what works and be aware of that. Absolutely.
Yeah. Very much so, and it chimes with what we heard from people and what sometimes the research seems to suggest, which is that the worrying idea that people who live alone might have less choice over their care and what happens because of that lack of another advocate or the lack of services being designed.
Well, and the ethnicity data, I mean, I can't really say more than that's what we found, that in general with these analyses, you take one group and compare and give the white majority, obviously, with a comparator here. And I say people of Black ethnicity were more likely to somewhat more, not somewhat more likely to be living alone, and people of Asian heritage less likely than the white majority. We just need to think about the needs of people living alone and to not disadvantage any group further. In terms of the policy impact, well, I mean, I agree. I think these, there is a need to evaluate, and I'll just go back to the initiative that I mentioned, the community agencies in the United States, where there was a very strong evaluative component, and that allowed us to learn a lot about how they can better support people living alone. And I think this is what we need to see, some really robust evaluations of practice that tell us what's working well and how we can improve.
Really important points raised there. And also just to say, in terms of the ethnicity point, so we have another project within DeNPRU Exeter run by Dr. Sadia Parveen around reducing inequalities for people from minority ethnic communities. And one of the important things that this research highlights is that difference between different groups, because it's far too easy to say, and I'm sure we've all heard this, of kind of, oh, well, different cultures, live in multi-generational families and there's lots of support around. That's not always true. And it can't always be true for lots of reasons. So I think, again, it's really useful to have these things highlighted.
Can I just also add, I mean, we talk about these things in great generalization. We talk about people with Asian heritage. I mean, that encompasses a huge amount of cultures and languages and customs. We have to think about personalizing this and think about, as we always say, each person with dementia is one person with dementia, and this is true as well for people living alone. In terms of the research, as you saw, there's very little that we were able to find related specifically to Huntington's.
Yeah.
What we did find in dementia, which is not necessarily directly relevant for Huntington's, is that the issues were more about what happened to you once you got into the healthcare system, and that was where the differences came. Now, my guess is that, I mean, you mentioned the government's agendas. I mean, I think this fits so well with the prevention, because we can talk about preventing crises, preventing things escalating. There is a public health framework that would talk about those kind of interventions as tertiary prevention. I think also the kind of keep hospital to community. I mean, you need better community services to keep people in place. So I think it fits, it does sit with those agendas, and we do present them in those agendas. Of course, they're very broad and possibly rather broad brush and perhaps a bit simplistic in terms of if you start to tease them apart and apply them, they become more obviously relevant. So I think that's really helpful. Care coordination, well, this was interesting as well. And again, the only research example we found was in dementia, but there was a German study that looked at coordinated dementia care management provided by specialist nurses. And that was, they looked at they had about 50% of their sample living alone. They recruited them in primary care. So it kind of matches with our estimates. They had half and half, not targeted in that way, but that's what they ended up with. And in fact, that intervention was much more likely to be cost effective for the people living alone in terms of managing, the challenges and crises they faced. It is interesting. The people living with others got more benefit in terms of how they reported their quality of life, but the people living alone appeared to gain more benefit in terms of how their care was managed and the results of that. So, I mean, it would be great to be able to see if that was, I mean, imagine that might extrapolate. It would be great to be able to see, but we don't find that in the research literature. So I think there are definitely agendas here for research. I mean, I know Huntington's needs a clinical guideline, a nice guideline. We keep making that point. There's a lot to do, but I think, these are really important questions. Rare diseases action plan, again, important to get things in there, as you say. Thank you. Those are all really good points. And just on the housing one, I'll just respond to say that was one of the specific recommendations that we pulled out and spoke to the DHSC teams about, that they actually, that they work with the relevant government department to look at that, because as you said, there's a massive amount of housing being built with probably very little consideration of its suitability in later life generally, never mind with other health conditions.
Yeah, thank you.
Absolutely. Thank you.
Well, that's really interesting. I was just talking the other day to a retired GP who is in the early 80s now, in his early 80s, and he recalls working in London probably at that time, and told me how older people living alone would be visited by a health visitor, even if they didn't have dementia, maybe every week, and they would have a chat, and the trainees would go and get to know them as well. As you say, how do we ever get back to that? Well, that's the challenge, isn't it? How do we get back to something that works as well as that, where people are known and can be properly supported?
So
Okay, thanks very much.
Lots still to do, but as Linda said, the work is not over and we are continuing on this. But just to say, we must stop there because it is lunchtime. Because you all have things to do and in your wonderful, hopefully sunny afternoon. But just to say thank you so much for joining us. It's wonderful to have this level of interest in our work, and it really helps kind of drive us forward and spur us on in continuing this conversation. So an enormous thank you to all of you.